All right. Good morning. Can those who joined through the online webinar use the raise hand function to confirm that they can hear this meeting? All right. All right, looks like we got confirmation. Thank you. Time is now 9:02 a.m. on November 12th, 2024. We are in the offices of the Texas Health and Human Services Commission, Public Hearing Room 1.403 in the North Austin Complex building in Austin, Texas. My name is Cole Hancock, a reimbursement analyst for acute care services in the Provider Finance Department at HHSC. With me at the table is Garrett Garzoni, also from the Acute Care Services in the Provider Finance Department at HHSC. Other HHSC staff and members of the public are also present at this hearing. The first in-person speaker is Dr. Yahya Mansour.
Well, really grateful for the opportunity to be here and really appreciate your guys' support and stewardship of the finances of the state as well as the health of the citizens of the state of Texas. So thank you. Just a brief background about myself. My name is Dr. Mansour. I'm the co-founder and chief dental officer of Rodeo Dental and Orthodontics. I'm also president of the Academy of General Dentistry here in Texas, in Fort Worth, Texas, and I'm licensed in 4 states, so I can see a big landscape across the country as well. We really appreciate the proposal, and what it amounts to really is a reshuffling of funds that ends up being net neutral. And our request is to support us in an increased budget and to really support the staffing and the kids that require these services in the state of Texas. When we look at states, other states and the fees, and we look at it in a vacuum, in a one-to-one view, it becomes quite difficult to see because of the competitive landscape that Texas is. There's a lot of businesses moving in here, and we've ended up becoming competitive with fast food chains. So we're losing skilled healthcare workers to fast food jobs. That's what it's come to, where the rubbers meet the road. And it becomes quite difficult to deliver care because we're working, the last fee increase we had was 2007. I know we had an adjustment in 2017, but the last fee increase was 2007, and $1 in 2007 is now $1.55 when you look at the inflation index as well. So as costs continue to rise, our fees are capped and contracted, and we keep getting squeezed and squeezed. So although we do appreciate the proposed reshuffling of funds in the proposal, we do ask for your guys' support in supporting us in getting an increased budget as well, just for the kids and for the staff in the state of Texas as well. We found that $1 in preventative dentistry yields $8 to $50 in savings in medical fees, and that can include ER visits. An ER state that's dental related can cost upwards of $1,000 to $1,500 a night, and this is something we can prevent with a $200 dental visit in preventative dentistry as well. We're really at a breaking point where we can no longer help support the staff and support to take care of our patients that frankly have the most urgent dental needs, the most urgent medical needs as well in the state, at lower fees, at a high administrative burden, which we're happy to do, but it's come to a point where the economics simply do not work as well. We can't, like I said, we can't change our fees just like the restaurant. If the price of beef goes up, they can change the price on the menu. We're unable to do that. Most of us that are Medicaid providers, we are here to help the community. We got into dentistry and other healthcare professions to help our patients, and it's become quite difficult to be able to do that, working on 15 years of no fee increases as well. So respectfully, we ask that you all support us in the legislature to increase the budget, and thank you for your time. Really appreciate it.
Thank you for your testimony. Our next speaker is Dr. Jay Shafi.
Hi, I'm Dr. Jay Shafi. I'm a managing partner of Lucent Dental Group. just to piggyback off of what Dr. Mansour said, the reason I'm here is to really highlight a staffing crisis that we're seeing at an individual office level. We're seeing a departure of our staff to other types of businesses, such as restaurants, and we're unable to compete with Chick-fil-A and other businesses. We're unable to pay our staff the proper amount. We've seen a 50% increase since the pandemic in payroll, and the volume of patients needs more staffing, and we're not able to keep up with the demand. And so the patients are being seen in a slower manner, and we're not able to maintain the proper pace, and we feel like the quality of care has gone down a lot because we're unable to see them properly. We request that, we know that the budget that you provided or the fees that you provided have to be budget neutral. We just really would want HHSC to recommend an increase in funding for the program so that we can have meaningful fee increases that it will help us keep up with the inflation that we've experienced the last few years. And it's been since 2007 since we've received an increase. Everything's increased in prices, and we are unable to keep up. And we're seeing a lot of offices on the ground going out of business. We're seeing shells of former offices that were seeing patients around us going out of business because they're no longer able to compete and maintain their business with the fees where they are. So, that's what I'm here for, and hopefully HHSC can advocate for the providers to receive some additional funding. Thank you.
Thank you for your testimony. Our next speaker is Dr. Sam Zarabi. Please give your name, job title, organization, home city, and topic.
Good morning. My name is Dr. Sam Zarabi, co-founder of Rodeo Dental. We are a large group, multidisciplinary group practice with 37 locations across Texas. We have comprehensive care with pediatric dentistry, oral surgery, endodontics, general dentistry, and orthodontics. We have almost 200 providers across the network servicing every panel except for one across the state, so we feel like we have a very good view across the network. I want to take a moment and thank HHSC, the Provider Finance Department, the Dental Director, Dr. Adderad, for the comprehensive work and thoughtfulness, appreciating the complexity of what we're dealing with in healthcare in the state of Texas in today's environment. I'm also here to really emphasize and reinforce that access to care is in trouble in the state of Texas currently, what we're seeing. Post-pandemic, as noted, we've seen a 25% exit of dental assisting staff and hygienists from dentistry, both in Texas and across the country. This has created incredible pressure on staffing shortages to then reinforce providing doctors with the teams necessary to see the patients in need in rural and underserved areas. We saw the first line of defense break at specialty, where we are seeing a 20% plus decrease in doctor days across the entire state. That's affected patient care, patients that need it. Recognizing and understanding the unbundling of the FDH code, but also recognizing the importance of what's needed here to create a sustainable network within the state. It's also important to recognize that early intervention, frequency, and education with fluoride treatment work. What we've seen at Rodeo is a 30% improvement of our patients that come in early in getting the treatment in the FDH program, in overall cost of lifetime to the state, and also frequency of procedures. There's a 30% improvement with those patients versus the ones that don't get that kind of care. So appreciate the state's work in supporting the thoughtfulness around frequency and early intervention. I can't stress that enough. Also taking into account some of the comparisons of other states, I want to recognize that Pennsylvania, one of the largest populous states, recently has had a fee increase as well. So I want to make sure that in our comparison to other states, Texas is taking that recent one into account. We have a network of almost 3,800 providers servicing over 3 million children. This is important to highlight because it shows the importance of the growth of Texas, but also a network that is strained and needing focus on the specific codes that the doctors are utilizing and treating so that we can improve access to care. And so as we go into legislative session, we ask that HHSC supports our work with the TDA, TDA-PD, ADSO, across all of dentistry to improve access to care for our patients in need. Thank you.
Thank you for your testimony. Our next speaker will be William Steinhauer. Please give your name, job title, organization, home city, and topic.
Okay, my name is Dr. William Steinhauer. I'm a pediatric dentist in San Antonio. I'm here today to testify on behalf of the Texas Academy of Pediatric Dentistry and myself. Thank you very much for allowing me to speak today on this very important issue. As you know, Texas Medicaid fees have not kept up with the current market, especially when it comes to pediatric dentistry. Pediatric dentists report they are paying 20% more for the cost of supplies and labor than they were paying just 5 years ago. Our Medicaid committee, the Texas Academy of Pediatric Dentistry's Medicaid committee, studied the proposed rates, and while they do not cover all the increased costs of seeing patients, we do support the adjusted rates for dental services. We understand for our members to be made whole, the legislature will have to appropriate additional funding to increase Medicaid fees. Every day, our organization hears from frustrated providers who are debating the heartbreaking decision of leaving the Medicaid program. These are specialists who provide the most complex care and are needed to ensure Medicaid kids are getting the care they need. We hope HHSC will support our efforts at the legislature next session so that Medicaid providers get a significant increase to Medicaid fees and are encouraged to stay in the program. Again, we thank HHSC for providing the Medicaid adjustment and encourage HHSC to support our request for substantial increases in the future. And I yield back my time.
Thank you for your testimony. Our next speaker is David Malave. Please give your name, job title, organization, home city, and topic.
Morning. My name is Dr. David Malave. I'm an oral surgeon from San Antonio, Texas, representing San Antonio Surgical Arts. First, I want to thank the opportunity to speak to you today, and I also thank you for the opportunity to review the Medicaid fees. We have been Medicaid providers for the last 32 years, a commitment that we take very seriously, have continued to this day, even though we face a combination of extremely low reimbursements, increase in costs associated with payroll, supplies, and the burden of managed care imposed by the state. We're currently the only private large oral surgery practice in our area that continues to provide care for the Medicaid children. 17 years ago, the last time that the rates were reviewed, our patients were coming from only the metropolitan area in San Antonio. Today, I can tell you that that area has expanded to include patients coming as north as Georgetown and as south as Victoria all the way to the border in Del Rio. This means that a significant amount of my patients travel 150 to 200 miles to come to see me. And if you ask the dental management companies, they will tell you that they have providers in those areas, but they really don't have providers for the needy, the kids under 12, the ones that the pediatric dentist cannot handle, the medical compromised patients, and the ones that require general anesthesia or inpatient care. So we are one of the few that can actually still treat them. So why is that there are fewer and fewer dental providers, including oral surgeons in Texas? It's very easy. It comes down to reimbursement. We have endured an astonishing 17 years of zero increase in reimbursement rates. 2007 was the last time Medicaid fees were partially raised. Yes, partially, as some codes were never actually increased at that time. There is absolutely no industry that can survive 17 years if your revenue sees zero increase in 17 years, while at the same time faced with an estimated increase in inflation, and according to the CPI, since 2007 to 2023, inflation has gone up 52.07%. Second is the cost of recruiting and maintaining quality employees. Our labor cost has gone up more than 45%, forcing us to absorb employees' raise with no increase in revenues. We don't have the luxury of leaving positions unfilled because we have an oath to take to care of our patients to one standard of care. There are no two standards of care. A standard of care for private patients, a standard of care for Medicaid patients. No, there's only one standard of care. So regardless if the state is underfunding Medicaid providers, we still have to, we uphold to the same standard as anybody else. Number three, as I explained earlier, large percentage of Medicaid patients have complicated medical, social, and psychosocial conditions that require more attention in our case, coordination with multiple dental and medical providers in order to be able to provide care for them. Just as an example, just to give you an idea of what we actually facing, I actually asked my administrative employees to trace a patient that was sent to us from 173 miles away for a procedure that Medicaid will pay me $64. And actually, according to the new rate, it's going to go up by a whopping $4. So now you're going to pay me $68 from the moment we encountered that patient, talking about seeing the patient, gather all the data, submit a pre-authorization to one of the Texas DMO, coordinating clearance from medical providers to finally book the patient for surgery. It took my administrative employees 3.3 hours of their work time. If I add my cost of employee time, overhead, supplies, my cost is around $157 to take care of a child who has a medical condition that requires treatment. When you add thousands of patients like this one, you get a clear picture that we are facing. We pretty much are subsidizing the Texas government for the care of our children. It's a shame. Finally, low reimbursement is providing an opening for more and more dental service organizations to buy out private practitioners. We in Texas value private property. We value private practice. There's always been a dream of every dental student to graduate and be able to open their own office and thrive and be able to provide their family and their employees a good living, and at the same time keeping that earnings in the state of Texas. So what happened is they are forced to sell to DSOs. And there's nothing wrong with DSO except their owners are not Texans. Most of these are hedge funds outside of Texas, except some local ones that we encourage them to continue. This means that Medicaid patients will not be a priority for them, and the revenues from all dental practices that used to be reinvested in Texas are now siphoned away to investment companies and hedge funds where profitability is the only north. Don't get me wrong, I appreciate this committee taking the task to relook at reimbursement rate, but I would have preferred that instead of looking at raw data some of it that is flawed, like the ADA study looking at minimal use CDT codes. And instead, this committee would have taken the time also to interview us, the medical providers, visit our facilities, interview our employees and patients to get a better picture of what we are going through. Bottom line is, if you want to bring the reimbursement fees to $2,024, every CDT code needs to be increased by 51%. That will equalize inflation for 17 years. That 51% should be the floor, not the ceiling. And on top of that, I still don't understand in cost cuts on some significant number of CDT codes or minimal increase. It really doesn't make any sense to me or to us. I'm going to point the 7 most utilized CDT codes by oral surgeons. CDT codes 7140, 7210, 20, 30, 40, 50. On 2 of them, you are lowering the reimbursement rate. So that means that now, 17 years later, you're going to pay me less on 2 of the most used codes. And on the ones that you have increased, 7241 and 7250, it was a fluke because they were never increased in 2017. So they were always lower. So now you're bringing it compared to what was increased in 2017. Honestly, you can tell in the tone of my voice, I'm not angry. I'm actually disappointed. If the proposed reimbursement fees stay the same as written on this document, I don't see any possible way for the majority of the oral surgeons in the program to continue providing care to our Medicaid children. The ball is on your court. I appreciate the opportunity, and let me know if you have any questions. Thank you.
Thank you for your testimony. We will now begin testimony for each virtual attendee. We will begin with those who have indicated on the webinar registration that they wish to speak. And we will start with AM Nas. Please give your name, job title, organization, home city, and topic.
Hello, my name is Aham Nahas. I'm from Houston, Texas. I've been a Medicaid dentist for over 10 years. I just want to make sure you guys are hearing me okay.
We hear you just fine. Please continue with your testimony.
Okay, thank you. Thank you for the opportunity to testify. I appreciate the webinar option. I started my private practice in 2015, and my practice serves a majority, low-income population. About 60% of my patients are children with Medicaid. I believe my practice is in a unique situation because I serve a population of mostly refugee and recent immigrant patients. So there are, like one of the previous dentists testified, there's a large administrative burden. I mean, these patients are very underserved. Even the social workers, nonprofits that are supposed to guide them don't often, have enough funds to do that and resources. So we're coordinating translators, transportation. We're coordinating referrals to specialists, and it's a huge burden on my staff. But we're happy to do it because, I mean, I started my practice to help the underserved, and I'm proud to serve the Medicaid population. But it is very difficult, especially with the skyrocketing inflation, staff wages. I've lost some of my best staff over the past few years because they've moved on to higher paying jobs. So, this situation at this time has become completely intolerable. I mean, this practice was my main source of, income up until the pandemic. And since then, I've had to take on, a second position outside of my practice. I work in emergency dentistry on the weekends, in the evenings, just to cover my costs. So it's no exaggeration to say that I'm subsidizing, the state's, healthcare costs by working for free, essentially. I mean, many of the services we provide are at a loss. So I just wanted to give more detail since you asked for specific codes for the testimony. So all the restorative codes, I mean, D2391, D2392, D2393, D2330, D2331, D2332, those are just the composites. But I mean, restorative treatment has become a huge burden. Most of the patients that I see come in with, very large decay restorations that require way more time than average. And, I'm getting paid in 2007 fees that are completely insufficient. So it's definitely a case where I've had to decide whether I want to keep my practice open and keep losing money, and I can't do it anymore. So if there's not a budget increase, if there's not a fee increase, that's going to be it for me and all the patients that I serve. I mean, there's no way I can go on like this. So the other codes, of course, that I wanted to mention. The preventive codes, I noticed there's a slight decrease on most of those. D0120, D0140, D0145, D0330, D1110, cleanings, x-rays, exams, all of that needs to go up, not, go down. And then especially D0145, the first dental home visit, is decreasing 61%. I mean, that's one of the only codes that we are able to make any kind of profit on, and that's going way down. So I don't know what exactly we're going to do. The last code I wanted to talk about. So the crowns, I do appreciate the increase in fees to the crown codes. I just hope that you guys will no longer require that we use high noble gold for molar crowns, because the lab fee is 4 times as high as their zirconia crown. So there's no reason for that. That rule is just a complete waste of money. We can't, most offices don't offer, that I've spoken to, don't even offer the gold crown option. So kids are going around getting root canals and then their tooth's just falling apart because nobody's putting a crown on that tooth, because we're required to use gold and the fee is way, way too low compared to the cost of gold. So please, I know that, or what I'm learning, that the budget is supposed to be a neutral adjustment. I don't know what that's about, but I don't see how that could possibly solve the issue. So I hope, you guys do whatever it takes to get a budget increase, or else, a lot of us are going to be out of business and unable to serve these patients. So I appreciate the time, and I'm happy to answer any questions whenever. If you guys have, more need for testimonies, this is my first time learning about these hearings, so I'm happy to contribute in the future. Thank you so much.
Thank you for your testimony.
Good morning. Can you guys hear me?
Yes, we can hear you. Please continue your testimony.
Wonderful. Good morning. My name is Dr. Armin Eliafendich. I'm a board-certified pediatric dentist practicing in Waxahachie, Texas, where I treat Medicaid-enrolled children, including those who are medically compromised or have special healthcare needs. I am here today on behalf of the Texas Dental Association to comment on the Texas Health and Human Services Commission, HHSC's proposed adjustments to Medicaid dental fees. During the biennial fee review, TDA advised HHSC against reducing Medicaid dental reimbursement rates. We thank HHSC for recognizing the need to increase Medicaid dental fees to reflect the actual costs dentists incur when treating Medicaid patients. TDA's Council on Public Health and Access to Care thoroughly reviewed all Medicaid dental program codes and strongly recommended against reductions to 78 codes essential to the program's effectiveness. TDA is pleased to see HHSC's proposal includes fee increases for most Medicaid dental services, particularly for a majority of the dental codes TDA identified as critical. However, TDA remains concerned about proposed reductions for radiographs, certain resin-based composite restorations, and removal of impacted teeth. TDA fully supports the First Dental Home Program, which improves the oral health of children aged 6 to 35 months. Although HHSC's proposal unbundles FDH program codes, we are pleased that D9994, Dental Case Management, Patient Education to Improve Oral Health Literacy, has been added to Medicaid Dental, ensuring that dentists can still be reimbursed for all services provided in a first dental home visit. TDA urges HHSC to retain the FDH program's 3-month periodicity schedule. While revising and updating the Medicaid dental fee schedule is a positive step, TDA recognizes that meaningful reimbursement improvements require the Texas legislature to increase general revenue funding for Medicaid dental services. To that end, TDA is advocating for a $250 million annual GR increase to restore Medicaid dental fees to 2007 levels adjusted for inflation. This funding is essential to ensure dentists can continue to participate in the Medicaid program and to guarantee access to quality dental care for all Medicaid patients. Thank you for your time.
Thank you for your testimony. The next speaker being Jerome Heaton, followed by Jeffrey Erickson. Jerome Heaton, please provide your name, job title, organization, home city, and topic.
Hi, my name is Dr. Jerome Heaton. I am a dentist anesthesiologist representing the Texas Society of Dentist Anesthesiologists. I am speaking in support of code D9222UZ and D9223UZ, as well as D9612. We appreciate the committee and those involved in increasing anesthesia rates for dentist anesthesiologist serving the children of Texas. I'm currently in Lubbock, Texas, and we have anesthesiologists for our company, Valley, and also a lot of the areas around the major cities and rural areas. And we've been operating, with dental anesthesia codes that have been about 25% of UCR. So we really, really appreciate the decision to increase the anesthesia rates and recognize the increased ability that will give us to help the children of Texas. And with that, I will end my testimony.
Thank you for your testimony. Our next speaker will be Jeffrey Erickson. Please provide your name, job title, organization, home city, and topic.
Dr. Jeffrey Erickson, President of Texas Kids Dental Care, El Paso, Texas, and topic is against the new dental fee proposals. Thank you for having this meeting. I wish this was an annual meeting, but I'm grateful for it today. I think this is a great step towards opening doors for a lot of people. A little bit different angle on the fees, but this is all about fees. I think the program is not broken at all, but it's hiding in the dark. And for us in the dental world, we have so many struggles, and I think our struggles deal with the DSOs because we never have a voice. And so I feel like they hide what's happening in the dental offices or suppressing providers' voice. And if they're representing us, we'd rather represent ourselves. And so it's been great to hear from so many dentists this morning. In regards to utilization, prevention, access to care, and quality of care, I think that DSOs represent that if the number of providers in the system is good, then all is well. And my argument today is that that's not the case at all. We have very, very slow access to care for our patients. There's inhibitions all the time by the DSOs. There's all kinds of paperwork. There's so many things that try to slow us down. We have to change, when a new patient comes in, sometimes they need to change their dental home. We have an office that's open at nights, and so that's difficult because their system is not open. And even when we do it advanced, sometimes the system says we need you to call a supervisor, and when you call the supervisor, they're not there. And so we frequently do a lot of dental care, dental treatment that we do not get paid for because of this inhibitory process. The DMOs have no idea about the quality care. They don't know who's doing work at the standard of care, and the more wages are driven down or the more fees are down, the lower the quality of care goes usually. They're very slow to respond. I can send an email today and I won't get a response for 3 to 5 days. They make the dental home very difficult. As they deny claims, and we can resubmit a very appropriate claim over and over again, and we have no recourse to ever get paid for that claim. It's a no win-win with the DMOs. A couple comments about relating to fees, just the standard of care. Here's what happens as we keep these low fees, the standard of care, even though someone spoke earlier, there is one standard of care, There's levels of that standard of care, though. For example, if I'm treating a 3-year-old client and I'm doing an anterior tooth, there's a high standard of care where I can do a nice composite tooth that looks like a tooth, a nice resin crown. It looks beautiful. It's very functional. Or I can shortcut that and do something that's really easy, but not very kid friendly for the next few years, which is a stainless steel crown. That pays about the same. It's easier to do. It takes me 3 minutes. And so what I've really done to the child is I've lowered the standard of care on him and put something that's really easy to do because the fees are so low. Another example was already shared, the gold crowns. Because the gold crown fee is different from a porcelain crown, we have to put a gold crown on a tooth that shows when people smile, and that's just because the fee for doing a more appropriate crown is so low that we would lose money every single time. Another thing that happens all throughout Texas is kids, when they get treated sometimes really well, but other times there's offices out there, again, lower standard of care. They put kids in a papoose, the kid cries for an hour, they get all the treatment done, so the DMO is happy because all the treatment's done with less invasive, no IV sedation, no conscious sedation, but the treatment's done, and no one knows this is happening because there's no evaluation of the standard or quality of care. And so again, low fees drive low quality. Some of these offices that do Medicaid dentistry, you walk in and it's simply gross. And it's because the lower the fees, the lower the quality. And so it would be great for the DMOs to be able to know what's going on in Texas so that they could recognize that, hey, we need to drive these fees up a little bit. We need to go to HHSC and say, hey, these fees are too low, and we're getting the compensation is we're generating lower standard of care. And every dentist wants to do a higher standard of care. And I'm not saying any of that's acceptable, by the way. But low fees will end up driving lower quality. Another one that was always expressed there is a lot of these dentists, instead of doing a crown, because the gold crown is so expensive to make and doesn't really pay that well, they'll put a stainless steel crown on, which again is a lesser level of care. But it happens all the time where they'll leave a buildup on there, which, as was stated, that will break, and over time is not as good of standard of care. And again, that's what lower fees drive. Restriction of care. It's the proposal of limiting providers by one of the DMOs is absolutely crazy because we're trying to generate more access to care, and their proposal is to reduce the number of providers. And what happens is they pass it on to HHSC and say, we have plenty. And in reality, like in our office, we have doctors who are full-time with the military, and they'll come in and work for us one night a week. So they'll do 3 to 4 hours, and they're considered they literally do 4 hours a week, and they're considered a full-time provider, when in reality, it would take 10 of those to equal one full-time provider. Even in our offices, when we do 50% Medicaid and 50% fee for service, those doctors are essentially a half-time provider in Medicaid, and those are counted, I think, by the DMOs as a full-time provider. And so these, when they come up with this criteria, if their only criteria for fees is the number of providers, that's a really, really poor criteria to use. Credentialing sometimes takes 9. We recently had a credentialing packet that took over 6 months. And so again, restriction of care. And how do you do this again with low fees? They do all these things. The DMOs are in there slowing down everything, slowing down care, when the program, HHSC, is all about access to care and availability of care and quality of care. And it gets lost with the middle management, if you will. Number of providers, let's see, down coding procedures. We had that experience recently. We've had it many times over the past few years where they'll take a code and they'll down code it, and they'll say, well, you did 2 surfaces, but we'll only pay for 1, which is obscene, right? That would be like taking a doctor who with a broken arm, treating a patient with a broken arm and saying there's 2 breaks, but we're just gonna treat 1. We'll treat both, but we're only going to pay you for 1. It doesn't make sense. And so these are some of the things we do with it. So how does that tie into fees? It just means the DSO is hiding all these things. It's hiding all these things So the HHSC really never knows what's going on, and we would love to have more of a seat at the table to make sure HHSC, as you've done today, thank you very much for doing that, knows exactly what's going on. And there's a lot of providers. I would think there'd be 1,300 providers, if that's how many are in the system, that would love to be on here today expressing their concern about these low fees. We can't maintain them because this 50% increase in expenses over the last few years. And truthfully, it has been shocking that the fees have not been moved in a positive direction, as many states are doing. Thank you for your time.
Thank you for your testimony. Our next speaker will be Dr. Kari Openeye.
Hello, thank you for taking the time. This is Dr. Kari Openeye. I'm a pediatric dentist with Rodeo Dental. And thanks. First, I would like to thank the HHSC for giving us the opportunity to bring some of our thoughts to light. Can everyone hear me, by the way? Hello?
Yes, we can hear you. Please continue.
Oh, okay. So, in addition, and I've listened to a lot of the speakers, and I think they touched on a lot of the good points. I just wanted to reiterate a few things around the ideas of fee adjustments that is critically needed to continue the provision of much needed dental care, not only to kids in this system, which is my field, but to all patients on Medicaid. Um, a few highlights that we can talk about why this fee adjustments is needed, considering the fact that it's not been done for over 17 years. That has now stopped a group like Rodeo Dental and a couple of my colleagues from investing in the most up-to-date dental equipment to provide service. But, the cost of doing business has gone up. Everybody knows about that. It's kind of hard to keep quality staff um, in the business because they just want more money, and the business has to be profitable to be able to do that. We can't really go out and invest in great dental equipment and materials because we just can't keep up with the fees. Then you talk about providers not even being interested in seeing patients on Medicaid. For kids, it's actually more is exaggerated because then the parents don't even want to come because they have no dentist who's going to provide the care, and naturally they just go to the emergency room. Um, I'm part of the dental department in a children's hospital, and this happens all the time because you then ask them questions. Uh, don't you have a dentist? This could have been handled. Simple filling here and there, but they just don't want to go to the clinic because they literally don't have any provider. Then they come to the ER, and the government is spending thousands and thousands of dollars to provide acute or emergent care to these kids. This is something I see day in, day out. They come in with abscesses, facial cellulitis, and then they have to go under general anesthesia to get the much needed care or part of the care, because after that they're left in limbo. Another thing that we've seen is denial of claims or restrictions of service. Um, I'm sure some of my colleagues on the line would agree, where you have things like, oh, you can do this, but you can't do that. You can do pulpal therapy, but you have to come back for the final. Like it's we spend a lot of money, and I know for a fact my group does. We spend a lot of money to do outreach to make sure patients are aware of the access to care that we're trying to bring together. Then they come in, then you find out that you can't even do certain things because some claims are denied, or it's just restricted, or there are restrictions. Then as clinicians, we're not really the best businessmen. We just want to provide care to the patient right in front of us. But now it's getting to a point you can't ignore the business aspect of it. You want to focus on the patient, but then you don't have, or you cannot really afford the material. So you have to downgrade as my other colleague had said, the standard of care is now adjusted. And when I say adjusted, it's actually reduced. You want to do zirconia crowns, but no, it's actually easier or more, or what is covered is stainless steel crowns. I have kids, and I will probably be a little, I mean, I will be concerned when, oh, sorry, I can't do this, but I can do stainless steel crowns. They don't look great. So I personally don't, and my group doesn't. We don't see patients based on insurance. We see patients on what they need, what is the best care available, and what can we do in the most predictable, affordable way for the patient to make sure the outcomes is comparable to anywhere on the planet, really. But we can't just do that anymore because it's just we can't keep up based on what we're currently being reimbursed. Um, and that has not stopped us from providing the care, but it's becoming increasingly difficult to do those. Um, we've talked about access to care, we've talked about competition, denial of claims, and staff are just not really being able to be there. Dentists are quitting, or dentists are actually closing their practices because they just can't do it anymore. It's not because they don't want to, but they absolutely cannot afford to do so. So while we appreciate the move to make adjustments, the adjustment needs to be significant to actually match the current market rates. Giving 2% or 3% doesn't really move the needle. It's something that's a move in the right direction, but we need something significant to be able to continue providing care to thousands or hundreds of thousands of kids in this great state of Texas. And I know we can do it. I know the will is there. We just bring things on the table, or bringing reason for this consideration to be done, and at least give us this adjustment on the most, because I know that's possible, the most the codes that are really done, the most completed procedures in the state for kids. I'm speaking because as a pediatric dentist, I'm more concerned about the kids, but I'm also speaking for all dentists involved here, you know, because I hate to always have to do emergency care and tell the kid, well, I'll see you later, when I can actually see them in the hospital. Preventive care is important. So is the restorative care. So when we see ideas of unbundling certain codes, when it's actually being pushed to like, well, we can only field, drill, and build. No, that's not the point. We wanted a holistic, comprehensive dental care to patients, and not have to worry about whether we're being paid or not. That's all I have for now. Thank you.
Thank you for your testimony. All right, I see some hands. Our first speaker will be Adam Lalonde.
Hello, everybody.
Hello, please continue your testimony.
Great. Just want to make sure you can hear me. Getting up because I'm in the middle of pulling a tooth to come talk to you guys. My name is Dr. Adam Lalonde. I'm the past president of Dentists Who Care. I practice in Los Fresnos, Texas. Dentists Who Care is one of the oldest dental charities in Texas. We won the award for best charity in Texas when our governor. So we've been around a long time, and I've had the opportunity to see a lot of children treated. I just want to speak a little bit to the dental fees and the reimbursement. Two quick facts that I want to throw out there. Everybody else has the dentists that have testified, I think, have made the main points. Health and Human Services budget in 2007 was around 210 billion. Their current budget is around 320 billion. So we've seen $100 billion of increase for Health and Human Services. The average salary for a director at Health and Human Services has gone up between 20 and 50% in the time range from 2007 to 2024. Meanwhile, the reimbursement for dentistry has gone down. We have seen several different downgrades in the reimbursement for our services. I don't know where the $100 billion has gone, but it certainly hasn't gone to dentistry. And I'd like to just kind of throw my support behind a further increase to the rates. I think some of the rates increase proposals are a little bit too low. 1 to 2% doesn't do much. I would be much in favor of the same approach that was done in 2007, where you look at the top 10, perhaps 20 codes that really drive quality dentistry and drive access to care, and look at reimbursing those. I think Texas can be a leader in this department. There's no reason we can't think about increasing cleanings, exams, x-rays, fluorides, sealants to a significant level, and let's drive preventative health care. And we know, everybody knows this, the more money you spend on prevention, the less you're going to spend down the road. You spend $1 on prevention, you're going to save $2 down the road in treatment. So I just would like to throw out there that the more you guys support preventive care and support dentistry in children, the more we're going to save this state in the long run. Appreciate the opportunity to testify.
Thank you for your testimony. Thank you to everyone who has provided and listened to testimony today. At this time, nobody else has indicated a desire to speak, so that is all the testimony we will be receiving in today's hearing. As indicated in the announcements, written comments on proposed payment rates may be submitted instead of or in addition to oral testimony until 5 p.m. today. Thank you and have a great day.